And in the virtual mode, it is very important to understand the process of ART initiation when the PLHIV comes to ART center. There are many issues, and those issues needs to be tackled properly. If those issues are not tackled properly, then later on he may he may be lost to follow. So first of all, as and when he comes and report to you, and at that time you tackle those problems, those things that will take care of your burden will be reduced for later visits. But later on also, we keep on telling him about the various adherence, how he should remain, continue with the ART, and he should adhere to the treatment. The session will give you insight into how the patient is to be registered, counseling session to ensure the patient is prepared for the ART initiation. The 7-step counseling tool is very important, and that will be told to all the participants. The initiation evaluation of the patient is also very important. Yesterday only we were in a meeting, we were discussing that there could be a tool also to find out who are the likely patient who can become, who can be lost to follow-up in near future. So from the initial counseling only, you will be able to know. So who are the patients whom you have to give a special attention. So that is also one of the thing, and you have to do the clinical assessment at which level the patient has reported. I mean, are they having any opportunistic infection or not? And these are, and then physical examination, the management of opportunistic infection, and the advanced HIV disease management. And all the staff of the ART plays an important role, right from the care coordinator till the medical officer. Everybody and is equally important. And medical officer, of course, is a team leader, and without the team leader, team cannot work properly. But each and every person is equally important, and their role is, we appreciate their role, and their job is very important to continue the treatment of the PLHIVs. Through this session, it will help to understand the role of different staff at the ARTC. Thank you all for joining. Over from my side.
Thank you so much, sir. I would request Dr. Reshu now to please initiate the session.
Thank you so much. Thanks, Dr. Puri, for setting up the context and laying out the importance of today's session. So can we move to the session now? Next slide, please. So I'm just repeating this from the previous session. So if somebody missed the overview session, so I just want to tell you all that on December 1st, 2021, NACO launched the revised National ART Operational Guidelines, and these have been circulated to all the ART centers states. So if they are not available, please let NACO know, and they can send these guidelines to you. So in December, in the month of January, we had an overview session on this, and now this series is basically more deep dive into the details of these guidelines. Next, please. Just to sort of again recapitulate from the previous session, so a lot of changes in last 10 years have happened in the guidelines, and the previous guidelines were revised in 2012. So after that, I think a lot of things had been introduced in the program, and program is moving towards patient-centric or person-centric care. So that's why there was a big need to revise these guidelines, and all these changes which are shown in this diagram, look, in terms of adoption of treat all policy, introduction of DTG, routine viral load, differentiated care models, expansion of the link ART center scheme, and revision of the data systems. These are some of the key things which have been revised in these guidelines. Next slide. So these guidelines are basically divided into two parts. One is the guidelines for the ART service provision for PLHIV, and these are mainly for the service providers, and they detail out the standard operating procedures for provision of care to PLHIV. Then there's a part 2 in these guidelines, which broadly deals with the implementation of service delivery models, and it gives more insights in terms of planning, implementation, monitoring of the program services, and continuity of the program services. So this slide is just to give you the overall organization of the guideline. Next slide. So in today's session, we would be focusing mainly on chapter 1 and chapter 2 of these guidelines, which deal with the service delivery models which are available for care, support, and treatment. And then the chapter 2, which talks mainly about the ART initiation. And just before we get deep into the sessions, I would just want to clarify that these the sessions are mainly from operational aspect. So in today's session, we would be mainly focusing on the operational aspects, and NACO is also revising the technical guidelines for management of PLHIV, and including the OI care, a new ART regimen, and as well as ADM package. So more details sessions on the technical part would be done subsequently. So in today's session, we would be basically discussing about the service delivery model for HIV care. And then under ART initiation chapter, we would be discussing about what is the process for registration, preparedness counseling, initial evaluation, and in terms, because now NACO is implementing treat all policy. So the focus is all on timely ART initiation. So we would be discussing the algorithm for fast tracking ART initiation, and then OI prophylaxis, and then we will briefly discuss about the advanced disease package also. And at the last, we will discuss about the flow of the patients at the ART center. Next, please. So coming to the first chapter, which is about the service delivery models for HIV care, support, and treatment. So those who have been working in the program or at the ART centers or at SEX level, they all know that under NACP, there is a 3-tier model for ART service delivery. The main delivery for the ART services is done by ART centers, which are located in medical colleges or the district hospitals, and in some states at sub-district hospitals also. Then to decentralize HIV care, the model of link ART centers was introduced in 2008. And these link ART centers are mainly located at sub-district level in CSCs and PSCs. And we will in subsequent slides discuss about the expansion of link ART centers to the community sites also. And then at the apex, we have COEs and ART plus centers, which are there to provide more comprehensive care to the patients who are sick and they need more complex care. And then all these is sort of complemented by the community involvement in terms of the care and support centers. Next slide, please. Next, please. So coming to the functions of ART center. So as I said, ART centers are basically located in the medical colleges and at the district hospitals, and they are sort of the heart for the service delivery for care, support, and treatment services. So the functions of the ART centers are divided into basically three categories, and one is the medical function, which I mean, we all know that's the core function of the ART centers in terms of like provision of ART to all the PLHIV, baseline and follow-up investigations, prophylaxis and management of opportunistic infections, including TB, screening the patients for any co-infection, comorbidities, then referral or management of the patients for advanced disease. So this is a new addition, and we will talk about this in more details in subsequent slides. Then patient-centric care or the differentiated service delivery models, patient education and counseling, CST referral, those who are like failing on the current regimen, and referral and linkages with the other specialty department whenever it is needed. So this is all about the medical functions, but ART centers are not just the clinical units or the medical units. They do have a lot of work to be done in the psychosocial aspects also. So providing psychological support to all PLHIV and caregivers, adherence counseling, education of the patients on nutrition, healthy living, education of the patients on sexual health, safe sex practices, then disclosure, supporting the patients in disclosing their HIV status to their family members, and supporting the testing of the family members, spouses, partners, and the children. Step-up counseling for the patients who are failing on the current regimen, and then their referral to CST for a next line of regimen, and then supporting linkages with care and support. So these are basically some of the psychosocial functions which ART centers have to perform. And at the lower box, we have programmatic functions. So ART centers, they contribute a lot to the overall national AIDS control program. So they are, as I was saying, they are just not, ART centers are not just the medical units, but they are largely like supporting the AIDS control program, or like supporting in a way to end the AIDS epidemic in the country. So ART centers are contributing to achieving the goal of 95, 95, 95, and also to end AIDS epidemic as a public health threat in the country, which is one of the SDG goals. Then proper recording and reporting as per national guidelines is very important. Tracking of missed and LFU patients with the help of DAPCOs, CSCs, ICTCs, link worker schemes, and whatever outreach functionaries are available within the program. Then coordination with the National TB Elimination Program for management of HIV-TB co-infected patients, mentoring of link ART centers and coordination with the link ART centers, and sensitization of the hospitals for care, support, and treatment services for PLHIV. So these are some of the programmatic functions, and which are really very critical. So ART centers need to, whenever like you are at the ART center, you have to look at all the three aspects of the ART centers, that the medical functions are being performed properly, the psychosocial functions are being performed properly, and also the programmatic functions are also given due focus. Next, please. Coming to the link ART center model. So as I was saying, this is more of a decentralized care model, which was started in 2008. And currently under the program, more than 1,200 link ART centers are providing care to patients. But going forward under these guidelines, the role of the link ART center in terms of like where the link ART centers can be established is being expanded. So till now the link ART centers were being established only in the public health facilities, but now beyond the public health facilities, that is beyond CSCs and PSCs, link ART centers can be set up at the OST sites, TI NGOs, care and support centers, prisons, or any other community level site at an NGO, CBO, or a CC. Or a CSO, but after approval from NACO or SACS. So this is a new addition in the link ART center scheme. Coming to the LAC Plus Center, so I think those who have been working in the program for a long time would recall that link ART centers were mandated to take care of the patients in pre-ART care. But now with the treat-all implementation, that function has sort of become redundant, and you don't need to keep your patients in pre-ART care anymore. So therefore, NACO has decided to revise the scheme of the Link ART Center Plus also. And going forward, Link ART Center Plus, Link ART Plus centers would be authorized to initiate ART after feasibility assessment by SACS and then written approval by SACS or NACO. Just coming to the functions, so this table describes the functions, and we will have a more detailed session on the Link ART Center, so I will not go in details of the functions. Next, please. Centers of excellence, so these are like more of the apex institutions which are supposed to work as model HIV care centers and provide excellence in clinical services, counseling services, data management, hospital infection control, biomedical waste management, and PEP. Other than that, they are required, or they provide comprehensive HIV care services in terms of ART services, pediatric patients, lab services, referral and linkages to specialty department, or expert consultation to all patients through telemedicine or through the expert panels. Then the other function which is served by the centers of excellence is basically the training and mentoring. So most of the centers of excellence are involved in doing the trainings of the ART centers and other field level staff. Then the other issue which is dealt by the centers of excellence is the research activity, and the centers of excellence are required to conduct some operational research, some multicentric research, which can inform the program policy. Other than that, COEs in a big way, they support the National AIDS Control Program and the SACS they are associated with in terms of the technical inputs to some of the policy decisions, data analysis, doing mentoring of the ART centers, implementing CQI practices, and then review of the ART centers. Next, please. This is a new concept about the community ART refill group. So I'm not sure how many of you have heard about this, but this is a new model which is being introduced particularly in the difficult terrains and hard to reach area. And this means that PLHIV can get their ART refills in a group, because especially in the hard to reach areas and some of the northeastern terrain, it was observed that it is very difficult for the patients to come for their monthly visits every time, and usually somebody else would collect the drugs for them. So NACO has decided to formalize this model so that the accountability of the group can be fixed for the patients, and then it is easy to monitor that the patient is getting continuous supplies of ARVs and it is adhering to the treatment. So these groups can be formed by any group of people which might be belonging to the same geography or same population, say for example adolescents or pediatric population or some specific key populations belonging to TIs. And these would be managed or facilitated by the PLHIV themselves or the community members or the peers, networks, CSC, CBOs, TI NGOs, or link worker scheme providers. Again, on all these models, there would be more detailed discussions in the subsequent sessions. Next, please. So moving to the next chapter now, that is about the ART initiation. So this chapter is divided into 6 sections basically, and the major changes which have been highlighted in this chapter are the treat all policy. So the because the initial guidelines, they in depth dealt with the pre-ART care, but that pre-ART care has become redundant now. So the focus is more on treat all policy, then preparedness, counseling, rapid ART initiation, operational aspects of advanced disease management, and this also deals about the roles and responsibilities of the staff. And some of the new annexures have been added to this chapter, which is the ART preparedness counseling checklist. Some changes have been made in the consent form before you start with the patients on ART, and then an annexure has been added on the index testing services. That means that facilitating testing of the partners or the spouse and the biological children of a patient. Next, please. So you all would recall that in 2017, NACO implemented the treat all policy, and now all patients are eligible for ART initiation regardless of CD4 count or WHO staging or any age group or any population type. Next, please. So with the treat all, these are the steps which are required for a patient to be initiated on ART. One is the registration in HIV care, then preparedness counseling, initial evaluation of the patient, OI prophylaxis and advanced disease management, and then ensuring that the patient is initiated on ART in a timely manner. Though this diagram shows these steps one by one, but that it does not mean that these are to be followed sequentially. These processes, these steps should be going on at the ART centers in a parallel manner so that a patient can be initiated on ART as soon as possible. Next, please. So the first step is registration in HIV care. So anybody who is detected positive at ICTC, he gets a post-test counseling at ICTC, and then he is referred to the nearest ART center or Link ART Center Plus Center. And then when he's being referred to an ART center for registration, he should be guided by the ICTCs that he should carry the ICTC report, valid address proof, 2 passport size photographs for the registration process. But if a person is not carrying any of these documents, he should not be denied registration at the ART center. Of course, the positive report from ICTC is very important, but in case a valid address proof is not available or passport size photographs are not available, patient should be asked to submit those in the subsequent visit. But registration should not be denied to any of the patients. And then the patient is enrolled and he is issued a white card and a green book at the ART center. Next, please. Preparedness counseling. So ART preparedness counseling is very critical, and from your experience at the ART centers, you would know that the initial time is very critical to retain a patient and to avoid the mortality also, because most of the patients we lose is in the initial 3 to 6 months only. So that this period is very important. And then ART is a lifelong treatment. So preparing the patient, providing him adequate information about the treatment is very important. So ART should be started based on the patient's informed decision and preparedness to begin with. And preparedness counseling comprises of the stepwise approach, which includes establishing rapport with the ART center, providing basic information about HIV, ART, providing treatment education that on what regimen he would be put, what would be the dosages, for or how long he has to take the treatment, and if he's being treated for advanced disease or any OI, then giving that, or TB, giving those specific information to the patient, guidance on positive living and prevention, encouraging disclosure, behavior and psychosocial assessment of the patient, and then developing an individual adherence plan for all the patients. So these are various components of the preparedness counseling. Next, please. Some of the key points for preparedness counseling is now, like with treat-all and viral load testing, things have changed. So whatever used to be the messages maybe 10 years back or 20 years back, they are not, in terms of counseling, the messages are not same. So ART staff should familiarize themselves with the new messages like rapid ART initiation, viral load monitoring, patient-centric care or differentiated care models, and then U equal to U, which means undetectable equal to untransmittable. If a patient is taking ART consistently, is the viral load is undetectable, then the chances of the patient to transmit virus to the partner is comparatively very low. So these are some of the new things which the ART staff should make themselves aware and use these messages in their counseling or when they're dealing with the patients. Then counselors to identify the PLHIV with high risk factors associated with poor adherence or non-retention. And Dr. Puri also in his opening remarks talked about that it is important to, like, from the very beginning know that which patients are having a very high likeliness of not being retained. Like these could be some of the migrants, key populations, alcoholic patients, or the patients who are not able to understand ART properly. So these are some of the groups, just to name a few. So these patients should be identified from very beginning and provided proper individualized counseling. Then patient-centric counseling should be provided to the special groups or special populations, which means like key populations because they have specific needs, children, adolescent, pregnant women, etc. So their specific needs should be addressed during preparedness counseling. Peer counseling support should be provided either by the care coordinator at the ART center or by the CST staff. So patients should be linked for peer counseling. And again, the caregiver is very important. So whoever is the caregiver of the patient, that person should be provided at least one counseling session in the initial 3 months. So that is a must. That is very important to do. Counseling and support, and then during the preparedness counseling, patient should be provided counseling and support for disclosure and testing of the spouse, partner, and children. And last but not the least, it's very important when we say preparedness counseling, it sounds it is counseling and it is the job of counselors only. No, this is not the job of counselors only. It is the team effort, and medical officers should also support the process of counseling. So because it depends, patient might I mean, something might click to the patient from anybody. So whoever the patient is coming or interacting with, that person should support the process of counseling, and the role of medical officers in the preparedness counseling is very critical. Next, please. Then schedule of the counseling session. So something, as I was saying, like sort of new counseling messages and new counseling strategies. So preparedness counseling requires a more of a reinforcement approach. So it does not mean that preparedness counseling is something which needs to be done just before the initiation of the treatment. So you start this process before the initiation of the treatment, but this process has to be continued even after the patient has been initiated on ART. And post-initiation support is very vital for the initial few months. So now the counseling sessions have been divided, or what would be the schedule of the counseling session that has been specified in these guidelines very clearly. So the first counseling session at the ART center happens at the day of registration, or that could be also the day of ART initiation. And we will discuss about the 7-point counseling tool, which Dr. Puri mentioned about. And then the follow-ups need to be done whenever the patient comes at the first follow-up after ART initiation. Then the second session of preparedness counseling needs to be done. When the patient comes for the second follow-up, at that time, the third session of the counseling has to be done. And when the patient comes for the third follow-up, the fourth session of preparedness counseling has to be done. So this would be preparedness counseling would be a continuous process. So in the beginning, you start the patient, you do a readiness assessment and provide the adequate information to the patient and start preparing him for or her for the lifelong ART, and you continue this process at least for initial 3 months. That is very important. And some of these patients might also require a more long-lasting support. So, I mean, based on the patient's requirement, preparedness counseling should be continued. Next, please. So as Dr. Puri was mentioning, that now NACO is introducing this 7-point counseling tool for ART preparedness, and this would be available as a ready reckoner. So if there are SACS team present in these sessions, so I would encourage you all to please get the printouts of these 7-point counseling tools, and they should be available as a desk reference or a ready reckoner to all the ART center staff. So in the 7-point counseling tool, this tool actually is divided into 7 steps. And what I mean, at each step, what are the important issues you should be discussing? Right. So the step 1 is basically you try to educate the patient about HIV and ART. So here you try to assess the education or the understanding of the patient about HIV and ART, and then provide him information that HIV is a chronic manageable disease like other chronic diseases, but it requires lifelong medication. So those messages should be going. Then message around the benefits of ART, that ART would help the patient to live a longer life, to live a healthier and a quality life, and the messages around you and you equal to you should be used while educating the patient on ART. And then you explain the importance of the adherence and lifelong treatment to the patient. Then step 2 is basically identifying patients' motivation to stay alive and healthy. So each one of us and each of the patients who come to the ART center, they would have their reasons or motivations to stay healthy. So those are some of the things which should be explored, and the benefits of ART should be explained in terms of those motivation which the patient has, or the reasons the patient has to stay healthy and to stay to live longer. Then the third step is identifying a caregiver. As I was saying, this is a very important step. And for each of the patient, one caregiver should be identified, and that caregiver should also be provided appropriate information about HIV as well as about ART, the adherence issues, the importance of adherence, the importance of ART. Next, please. Step 4, you identify the potential barriers for adherence. As we were discussing earlier also, that there are patients belonging to some special groups, or they might have some specific issues, like, it could be distance, it could be money, it could be like, some psychological issues. So those are those barriers should be identified, and patient should, and at the time of counseling, we should try to address those barriers and tell the patient that how he can like overcome those barriers. Or maybe not immediately, like say if it is an issue of distance or money, you could tell, like, if you like stay on treatment for first 6 months, then you would be eligible for multi-month dispensation. So these initial 6 months are very critical, and then you don't need to come to ART center every time. You don't need to spend long traveling hours or money for traveling. So those are the kind of things. But it is very important to identify the barriers from the very beginning and customize the plan for each of the patients. Then identify the strategies for good adherence. So this I already discussed, like, based on the barriers, you will have to like tell the patient how he can overcome those barriers. And for adherence, you could think of some reminders, how the patient would remember that he has to take his pill at the same time. So it could be, you could like link it with some of the TV shows he's seeing, or put some alarms, reminders. So whatever way would work for him. Or you could like give this responsibility to the caregiver also, that every time this patient has to take his ART at night. So every time at night, you have to remind the patient that he has to take the ART. So those kind of things, and the adherence plan has to be like ensured. Then devise a treatment plan that suits the patient. So every patient is different, their needs are different. So you have to advise the patient that he has to take ART at a fixed time every day, and preferably we advise night time. But however, if it's not feasible for the patient, he can be guided to take medicine at any other time of the day, but it has to be a fixed time. Then like where will he store the drugs, what would be the reminder tools he will be using, and then what he would do if he has missed the drug. So now most of our patients are on TLD single pill. So if the patient has missed the pill and he's reminded within 12 hours of missing the pill, then he should take the pill. But if 12 hours have passed after missing the pill, then he should wait for the next pill to be taken. And then if the patient is on some OI medication or TB treatment, then he should be advised like how those medications are to be taken, and also about the drug interactions with ART. Like if a patient is taking some multivitamins, antacids, or laxatives, they should be taken at least 2 hours before or 6 hours after taking ART. So those are the messages which are very important and needs to be given to the patient. And then at the end, do tell the patient that when he's supposed to come back. This step is very important. At times, like at ART centers, we feel that it is monthly. A patient has to come back every month. But telling the patient like which date, is he comfortable coming on that date, or he wants to come 2 days prior or 2 days late. So those discussions should happen about the next appointment at every preparedness counseling session. Next, please. You can skip the slide. Next, please. Next. Previous one. One before this. Right. So as we were discussing that a new ART preparedness checklist based on this 7-point counseling tool has been added. This is given as an annexure in the guidelines, and going forth, all ART centers are required to maintain this checklist or the form for all the patients who would be newly initiated on ART. So this is a new format which is being introduced to ensure that the patients who are newly initiated on ART, they are retained and they are provided proper preparedness counseling. And this would help the counselors also, because at times what happens, there is no record of the discussions which you did in the previous session. Patient might have told you something and you might have advised patient something to overcome that barrier, but when the patient comes next time, you might forget that. So this is basically to document the entire process of preparedness counseling so that it is easy to follow with the patient in the next session and you don't have to start from the very beginning. Because patients also at times feel frustrated that I told last time that okay, this is difficult for me, or no, I have this issue, but I mean that was not documented or that was not registered by the ART staff, so that at times offends the patients also. So it is very important to keep a record of the documentation, and this preparedness counseling form has to be inserted in the white card of all the patients and has to be maintained for first 3 months. Next, please. Next. Coming to the next step for ART initiation, this is the initial evaluation. So a comprehensive clinical and laboratory assessment should be done for all patients, and this is to determine the WHO clinical staging of the patient, any need for the OI prophylaxis, what would be the optimal ART regimen for that patient, and then any psychosocial or nutritional needs for the patient. The steps for the initial evaluations are further divided into 3 parts. One is the clinical assessment and history. So it is very important that whenever a patient is being registered at an ART center, so a proper, thorough clinical assessment of this patient should be done and the history should be taken. Then physical examination and baseline laboratory evaluation. Next, please. So for baseline lab investigations, this is the list of the baseline lab investigations, which is to be done for all the patients. So on the left side, you see the essential ones, which means hemogram, fasting blood sugar, blood urea, serum creatinine, serum bilirubin and ALT, CD4 count, urine routine, and microscopic X-ray chest is to be done for all patients, and for women, cervical pap smear or a visual inspection with acetic acid or any other way of screening for cervical cancer should be done. And on the right side, you see some of the additional investigations which are based on the patient's condition and physical and physician's decision. So the medical officer at the ART center would decide, suppose if the patient is having any symptoms or signs for any of the OIs, or his 4 symptom positive for TB, then he should be subjected to the detailed investigation for TB or other OI. LFT is to be done for the patients who are Hep B, Hep C co-infected, or if available, it can be done for the patients who are being initiated on ATT. Lipid profile. Then HBsAg and HCV antibodies, especially for key population and high risk population, needs to be done. Fundus examination for the patients who are reporting with CD4 count less than 100. VDRL test, anal pap smear for MSMs, and in the areas which are endemic for Kala Azar, RK39 strip test should be done. Next, please. Then coming to the last step or the ART initiation. So as we discussed that the ART after a proper ART assessment of the patients for treatment readiness by the counselor, the ART should be initiated by the medical officer. Treatment should be started based on the person's informed decision and preparedness to initiate ART with information and understanding of the benefits, lifelong course of medication with good adherence. And whenever you start the patient on ART, the consent form has to be signed. So it has, for the adult patients, it has to be done by the patients themselves, and for the minor patients, the caregiver has to sign these consent forms. And there is some revisions which have been done in the consent form, so you can refer to the revised consent form given it as an annexure in the revised operational guidelines. Next, please. So now we are implementing treat all policy, and you all know about it. And when we say treat all, it means that it supports that a rapid ART initiation, including same day initiation, should be done wherever there are no clinical contraindications. So if a patient is ready for ART initiation and he does not have any clinical condition which contradicts ART initiation, he should be offered ART either on the same day or at the earliest possible. But if he has some OI or some condition which warrants the delay in ART, it is up to the doctor's decision. But because most of our patients who come to the ART center are asymptomatic and do not have any clinical contraindications, so they should not be and their ART initiation should not be delayed, or they should not be asked to come to ART center multiple times before ART is initiated. So unless clinically you really feel that the ART should be delayed, then only ART should be delayed. Next slide, please. So in the ART operational guidelines, and this was also issued as an OM by NACO, and we had a very detailed discussion and also an NDLS session on the fast track ART algorithm. So this is the algorithm which NACO has designed to fast track the ART initiation, and this is based on the symptom screening. So if the lab investigations are not available, if they are taking time, so patient should be subjected to the clinical screening, and based on that clinical screening, you should decide whether the patient is can be initiated ART immediately if the patient is ready to be initiated on ART. Otherwise, you can always manage the condition and then start ART. So next slide, we'll discuss this algorithm in more detail. Next, please. So this is just the detailed expansion of the same algorithm. So what you do is whenever the patient comes to the ART center, so you do a detailed symptom screening for the patient, and you all know about the 4 symptom screening. So cough, fever, weight loss, and night sweats is anyways being done. And then you also assess the patient for any persistent headache or any other serious symptoms. So, and if there are any symptoms, then the patient should be referred or for appropriate management or diagnosis, which could be done at the ART center, or you could refer the patient to a specialty department also. If the patient does not have any of the symptoms, then a thorough physical examination of the patient should be done, and patient should be any signs of serious illness should be excluded. So if there is a temperature more than 39 degrees Celsius, respiratory rate more than 30 per minute, heart rate 120 more than 120 per minute, or altered mental status, or any neurological condition, if the patient is not able to walk unaided, or any other condition which you think needs emergency management, or so in those cases also, patient should be referred for appropriate diagnosis, management, or expert opinion. If the patient does not have any such condition, so previous please. Yeah, if the patient does not have any comorbid condition, any signs of serious illness, then any patient should be asked for any comorbid condition. Does the patient is already having TB? Or is the patient having any history of kidney disease or uncontrolled diabetes or hypertension? So if these issues are there, then we might want to examine and do a proper lab investigation of our patients before initiating them on ART, and also to find the right ART for these patients. Next, please. Next slide. So if the patient does not have any, when you screen for the symptoms, patient is not having any symptoms. When you screen for any signs of serious illness, patient does not have any signs, there are no comorbid conditions present. In those cases, you just do a readiness assessment of the patient. If the patient is ready for ART initiation, and if there are no psychological concerns for ART initiation, then these patients should be initiated on ART, preferably on same day. Right, and these patients should be dispensed ART for 1 month. It has been seen in many of the centers that at the time of ART initiation, people are not dispensed 1 month's drug. So ART dispensation has to be done for 1 month in such cases. And concurrently, their blood samples for CD4 lab, CD4 investigations and other lab investigations should be drawn, and they should be subjected to proper lab investigations. And a follow-up should be done for all patients after 2 weeks. If there are any issues with the results, if you find any deranged or abnormal results, then these patients should be called back to the ART center for any referral or further investigations, diagnosis, or maybe if they require a change in a regimen. So that has to be done by the counselor at the ART center, and that should be done within 3 to 15 days whenever the reports of the investigations are available. And the patients in which you delay the ART, for those patients, once the patient has got stabilized, the issue for which the ART was delayed, that has been sorted, then the ART can be initiated as per the technical guidelines. Next, please. So again, there is a change in the ART initiation policy for the patients who are co-infected with TB. So patients who are having HIV and TB co-infection, and if they need to be initiated on ART, they should be initiated as soon as possible within 2 weeks of initiating TB treatment, regardless of the CD4 count. So the earlier guidelines which said that they should be initiated on ART 2 weeks after and within 2 months, that guideline has been changed now. So all patients should be initiated within 2 weeks of initiating anti-TB treatment. The only exception here is basically TB meningitis, where ART should be delayed for 4 to 8 weeks. And patient should be started after stabilizing of the TB meningitis. Next, please. Then the other thing which is very important for all the new patients who are being initiated on ART is the OI prophylaxis or the preventive treatment. So all patients who are stage 3 or stage 4 or have CD4 counts less than 350, they should be given CPT, and CPT is to be continued till the time patient has CD4 count more than 350 on 2 different occasions 6 months apart with an ascending trend, and he does, and his clinical stage is not stage 3 or stage 4 anymore. And then all the HIV infected infants and children up to the age of 5 years should be provided CPT irrespective of the CD4 count or WHO staging. The other preventive treatment which is recommended for all the patients who are initiated, who are registered at the ART center, is a TB preventive treatment, and all patients should be provided 6 months of isoniazid preventive treatment, and should be guided and also monitored for completion of TPT. Next, please. So management of PLHIV with advanced disease. So I think you all must have been hearing about this advanced disease management term for a long time, and it is nothing but it is sort of like bringing everything as a package now. So you, as at ART centers, you people have been doing most of the components you have been like providing to the patient, but that has not been done in a more systematic manner. So when we say advanced HIV disease, what it means? So the patients who are adults and adolescents and children who are more than 5 years, they are defined to be having advanced HIV disease if their CD4 counts are less than 200, and if their WHO clinical stage is stage 3 or stage 4. All children younger than 5 years who are not receiving ART and are not stable, they are considered as the patients with advanced disease. Next, please. So the various components of advanced disease management are: first is screening, diagnosis, and management of the common OI. So you people at the ART centers have already been doing for symptom screening, but it is like not doing it in a more systematic manner. And then there are new tools which are being introduced, and the program is working towards introducing those new tools in terms of TB LAM and antigen testing, but it might take some time for implementing those tests. But whatever is available with us currently, even within that umbrella, if we do a very systematic screening of the patients, we would be able to identify a lot of common OIs, a lot of patients with the OIs, and then the aim is to manage these OIs appropriately and timely. Then the other piece of ADM package is to give the prophylaxis or the preventive treatment for serious OIs, and this includes TB preventive therapy and also the preemptive treatment for the patients who would be tested cryptococcal antigen positive. The patients who are not having any symptoms, or those who are ready for ART, they should be provided rapid ART initiation. And as soon as the patient has been stabilized after OI management, they should also be provided rapid ART. So timely and rapid ART initiation is a key. And then the fourth thing, and which I think all of our ART centers are very much well aware about, is the tailored and intensified counseling. And when we were discussing about the preparedness counseling, that's what we discussed, that these patients should be provided at least 3 months of intensified follow-up in terms of counseling. So that piece of tailored and intensified counseling, and if you need to check in with these patients more regularly, that is very important. And even the CST staff could be could support the process of doing a more intensified counseling and follow-up of these patients. Next, please. So this is the flow diagram which has been added in the guidelines, which talks about the operational flow of the patients, how the patients with the advanced disease management would be identified, and what is the role and responsibility of each of the staff, and how do you manage these patients, and when do you refer them. So next slide, we'll discuss in more details. Yeah. So whenever a patient visits the ART center, so the care coordinator does the 4-symptom TB screening: cough, fever, weight loss, night sweat in adults, and then and adults and adolescents, and then cough, fever, weight gain, and contact with a TB patient in children. So that 4-symptom screening has to be done by care coordinator, as is being done currently. Then at the counselor level, when these patients come, then this, they should be assessed or asked for the CD4 counts. So if the CD4 counts are less than 200, patient is virologically unsuppressed, if the child is less than 5 years and not stable on ART, 4-symptom screening for TB is positive, and if the patient is having any persistent headache or any signs of serious illness, then they should be further evaluated. And if these signs or symptoms are not present, then these patients can be provided the standard package of care. Now you would be realizing that when we were discussing the algorithm for rapid ART, that algorithm was vice versa. So that means like the patients who does not have any advanced disease can be initiated easily, and their ART can be fast tracked. So the patients who have any of these conditions, then they should be like evaluated further by the nurse. And as per the guidelines, 4-symptom screening is to be repeated by the nurse. Then they should be screened for the persistent headache or any other serious illness. They should also be examined for any signs for serious illness, like as we were discussing, temperature, higher respiratory rate, high heart rate, any altered mental condition, any neurological condition, or any other condition that requires management. Next, please. So if the patient has any such condition, that patient is symptomatic or he has any signs of serious illness, then these patients should be immediately referred to the medical officer, and their screening for TB and other serious conditions should be done. And if they are confirmed for advanced disease, HIV disease, or having any of the signs of the serious illness, then they should be further worked out. And if the medical officer feels that they don't have any signs or symptoms related to advanced disease, then they should be provided the standard care of package, which we discussed till now. So the patients with the with any serious symptoms or advanced disease. So these would again be divided into two groups. One is like patients with very severe signs of serious illness, and these patients may not be managed at the ART centers itself. They might require some hospitalization, inpatient management. So such patients should be referred for hospitalization or to a higher center where they could get a more appropriate specialty opinion and management. And then once they are stabilized, ADM package should be provided to them. And then there would be a group of patients who don't have any signs of serious illness, but they are still like CD4 less than 200. They might have mild symptoms and or they might be WHO stage 3 and 4. So these patients are to be provided the advanced disease package. And under this package, what we have is basically screening, diagnosis, and treatment of OIs, prompt initiation of the OI prophylaxis or preventive treatment, rapid ART initiation, and intensive counseling support. Next, please. Next, please. Yeah, so I'm on my last slide now. So this previous one. Yes. So this slide describes the flow of the patient. Just to simplify the things, this flow is more or less what we had in the previous guidelines. So patient visits the ART center. The first point of interaction at the ART center is the care coordinator, and then you have the roles for care coordinator in terms of peer education, psychosocial support for the patient, for symptom screening, giving the or issuing the white card to the patients, and then maintaining the patient visit register. And then the patient goes to the counselor, where the counselor does the preparedness counseling, for symptom screening for advanced disease, for HIV, then validate the phone number, identification of the caregiver, link to the community referral or to care and support center, coordinate with the staff nurse for the patients who are sick, and then enroll the patient in the HIV care register, and maintains the white card of the patient and the green book of the patient. Then the patient goes to the staff nurse, where the 4 symptom screening has to be done. Any patient who is requiring investigations or admissions their referrals should be made by the staff nurse. Screening of the vital parameters, assessment for the advanced HIV disease, patient education on medicines, follow-up of the patients who are in the IPT or who are like admitted, ensuring TB treatment in patients who are co-infected with TB, and then screening for non-communicable disease. And then the patient goes to the medical officer, where medical officer does the detailed history, clinical assessment, physical examination of the patient, and decides whether the patient is if the patient is not having any clinical contraindications, then the patient can be initiated on ART. Otherwise, the patient should be sent for appropriate diagnosis or referral. And then after that, the patient goes to the lab technician if required, like for whatever investigations have been prescribed by the medical officers. Some patient might be referred to other departments or the IPD for hospitalization, and some patients would be like, obviously 80 to 90% of our patients would be initiated on ART, and those patients should go to the pharmacist and collect their drugs. And once that is done, patients should also be linked to the care and support centers. And this is how the overall flow of the patient at the ART center is to be maintained. So with this, I've discussed all the slides which I had, and we can open for questions, discussions.
Thank you so much, ma'am. Participants, you can please unmute yourself and ask the questions if you have any.
Good afternoon. Am I audible?
Yes.
Yes, Dr. Resu, thank you for the elaborate presentation. So I have one question.
Those who are not speaking, can they mute their mics, please?
Yeah. So, like in some interior ART centers, like in Northeast, where we may not have ART medical officer, but a SMO or a medical officer in the institution is available. In those places, how we can operationalize the ART initiation practices, since there are challenges where the patient either have to travel to the nearest ART center, which is 4 to 5 hours of journey, and it costs also. And by the time they reach also the other ART center, it might be closed, or the queue is large, so they have to wait. So under such condition, what this guideline could, offer in such situation? My second question is, what we have found that a lot of our patients accepting their result that I am positive, and understanding that actually treatment works with patients is a key point where they could take a decision. Yes, I can take these medicines, right? So can we, or maybe we can think of adding a lay mental health assessment tool to those cases, because that is critical. Currently, whatever we are doing, it is more clinical. We are looking at the clinical eligibility of the patient. But when it comes to the psychosocial eligibility, especially the psychological part of it, that yes, I am positive now, and then treatment is working, I can take this treatment, is critical. Thank you.
Thanks, Dr. Subhash, for raising those very important and critical points. Of ART initiation, I think this clinical algorithm for fast-track ART initiation is a step towards that. So, and also NACO's initiative towards authorizing the LAC plus centers to do the ART initiations at lower level hospitals. So that is one of the modalities which NACO is currently looking at in terms of decentralizing, and this hopefully this strategy would be very critical for the difficult terrains. And we will be discussing in subsequent sessions also. So I know NACO is also working on the telemedicine concepts and also linking the peripheral sites with the nodal ART centers or the higher institutions where the lower hospitals or the lower centers could be provided guidance on ART initiation. So those modalities are already being worked out by NACO, and I think, but the only thing is, like, for ART initiation currently under the program, the requirement is that that site should be LAC plus, should be registered at LAC plus, and there should be some institutional ownership, and also reporting in terms of ensuring that the patient is continued on treatment. So this should not happen on ad hoc basis. And then your second point regarding the mental health issues. I think in this series we have a session on the comorbid conditions, which includes the mental health issues, and we will discuss about those mental health issues in that session in more detail. So that is very much the part of the revised guidelines.
Yeah, thank you, Dr. Desu. So just to add, this is a typical situation in Northeast, state of Nagaland, Noklak. I think your team must be knowing, and ITech team must be knowing. So Noklak ART Center is a ART center which is currently having about 300 patients, but there are no ART medical officer, and the senior medical officer is not able to prescribe, medicines or initiating ART. So I would request if the Nagaland SACS and NACO could look at, what can be done, because we are working there with CLHIV, and parents often hesitate to, accompany their children to the nearest ART center, which is 4 to 5 hours journey. Thank you.
Thanks, Dr. Subhash. And I think a lot of flexibility is available in these revised guidelines, which can be utilized by SACS. So NACO and SACS can work towards it. Thank you.
Thank you.
Ma'am, there were a few questions from the chat also.
Okay.
Praveenji, please share. Yeah, thank you.
So if I'm reading this question is about the steps for registration. So a patient who is detected positive at ICTC has to be referred to the nearest ART center, or if the link ART center plus center is authorized for ART initiation. So just to clarify that the referral has to happen to an ART center or a LAC plus center authorized for ART initiation. And this is again, we do say nearest, but it is based on the patient's convenience. So no patient should be forced to go to any particular ART center or LAC plus for registration. I think the second question is like, in the era of a treat all same day policies, pre-ART registration is still required. So we will discuss about the definition of the pre-ART thing in the next session. But yeah, the registration in HIV care is very much required. So that registration has to be done, and then patient can be like, based on the clinical condition and readiness, patient can be initiated on ART on the same day, or if a delay is warranted, then a delayed ART can be done. I think for Northeast, we have already discussed. Subhash has already alluded to this question. Next, please. So there's a question about the TPT guidelines. So as of now, the guideline which is being practiced is basically to give INH, isoniazid prophylaxis, for 6 months. Repeat courses are not recommended, or like repetition or next round of course is not required, is not recommended in the guidelines as of now. And again, on the TPT, when we discuss the session on comorbidity, we will have a more detailed discussion that for how long it has to be given and how the follow-up of the patients is to be done. So I think this issue, isoniazid preventive therapy, can lead to drug resistance. Again, I'll just say that if you do a good 4 symptom screening, the negative predictive value of 4 symptom is really very high, up to the extent of 99.5%. So that means the patient might, likeliness of the patient having TB is very, very, very minimal. And that's why NH therapy is recommended. And again, and there's no risk of like actually inducing drug resistance in these patients. But a very good 4 symptom screening is a must. That piece is very critical. And again, we will discuss about the issues around INH therapy in the session on HIV TB. Then we are initiating IPT 3 months after ART initiation. Is there a change in the guidelines, and do we need to start IPT along with ART? So I think there is no guideline to wait for 3 months. IPT can be started as and when you are confident that the likeliness of the patient having TB is very low. So this guideline of 3 months does not stand anymore. If you are, if the patient does not have any symptoms, and if you have done a good 4 symptom screening, patient can be immediately started even along with ART. But if you are unsure that the patient might have TB, or you are not able to exclude TB, in those cases, it might be good to wait for some time. But obviously, as per the advanced disease package, it makes more sense, and the value addition of doing IPT at the earliest would help to save patients from developing TB and decreasing the TB related mortality. So unnecessary delays in IPT should not be done, and this 3 months guideline has been removed from the technical guidelines also. Next, please. Crack not available everywhere. So can we do with CN2? Listen. So I think on this we will have one on the crack piece. NACO is trying to work on the modalities of the implementation, and you would hear from NACO in the times to come. And we would have more detailed discussion when we discuss the technical guidelines on what are the alternatives when you don't have cryptococcal antigen available at the ART centers. Next. Is that all?
Yes, that was all.
Okay. I think if Puri sir has any comments. It's fine.
Dr. Rivari is also with us, ma'am. Sir, if you want to say anything.
No, I just said it was a useful session, and there are some new changes which has occurred in the operational guideline. And I'm sure there would be more sessions also coming in to deal with the later part, other parts of the operational guideline. So ART initiation and expansion of Link ART Center, 7-point counseling tool. These are some of the highlights that has come in. And of course, the focus on U equal to U and advanced HIV disease, which counselors need to basically focus, is an important part that was highlighted today. Thank you.
Thank you, sir. Thank you, ma'am, and thank you to Dr. Puri. This session was very useful. Thanks to all the participants for patient listening. We shall be soon sharing the recording of today's session. The next session of this series is now scheduled on 15th of February on the topic monitoring and follow-up and differentiated care packages. We shall be sending you the session link on email soon. Thanks again. Have a great day.